My topic is the combination of talks what they have spoken in the last 3-4 topics. The topic of the Dr. Kirti and Dr. Naren combining the sepsis, myocardial injury in a non-cardiac surgery patient. The patient is 55 years male, occupation by farmer. Risk factors wise, he is diabetic, and he had a previous history of admission 6 months back with chronic pyelonephritis, and from then on he is in CKD stage 3 with no history of hypertension, CAD or dyslipidemia. This was the previous admitted with the pyelonephritis, sepsis, at that time normal LV function. He was treated with IV antibiotics and insulin and fluids, and he was improved and discharged. The current admission is for the fever for 5 days, abdominal pain, vomiting and hyperglycemia. These are the inflammatory markers with the rise at CRP. Procal obviously is in sepsis, and creatinine mounting up from 2.3 to 5.3. The imaging shows the CTKOB, hydroerythronephrosis and bulky kidneys with infection, emphysematous changes, and the blood grows the E. coli. This is the admission ECG, which is showing some sinus tachycardia. We all think of it is due to the sepsis and fever. And this is the chest X-ray, which is more or less clear. So the urological procedure wise, he underwent left DJ stenting under local anesthesia, the pus drainage and from the PCS. Immediately after the procedure, he developed sudden dyspnea, pulmonary edema, and requiring the NIV support. So we all thought why this sudden increase in sudden onset of pulmonary edema. So in this patient, we can think of multiple causes like sepsis causing the capillary leak and ARDS like picture, or CKD causing the volume overload, or any LV dysfunction or ischemia causing the pulmonary edema. The troponin was 14,000. Just now we have a discussion on means that is myocardial infarction in non-cardiac surgery, and echo is showing new onset RWMA and ECG showing sinus tachycardia. This is the post-operative ECG, and this is the X-ray. Definitely we can see when compared with the first X-ray, there is a pulmonary edema. So we are stuck here, and post-DJ stenting patient developed pulmonary edema with positive cardiac troponin and new onset RWMA. Now we have to do either intervention or medical management. For going an intervention with worsening of creatinine, subjecting the patient for this sin. And if you are thinking of medical management, already the patient developed pulmonary edema and requiring NIV support. So without intervention, for ischemia may further worsen. So after discussing with the nephrologist, we are ready to do the dialysis if requirement, step-ins, and we went ahead with the angiogram. So the angiogram showing a lesion in the LAD and LCX. And we have done an OCT for the LAD in view of the intermediate lesion in the LAD, and to demonstrate exactly where there is any plaque rupture or thrombosis. There is a lipidic plaque with stenosis of 60 to 70%. And we have stented both the LAD and LCX. And the AKA worsened after the PCA as expected. Regions may be to the SIN, or it may be a baseline CKD or hyperperfusion or sepsis. So gradually the patient has improved, and we are able to discharge after a week with the creatinine of 3.2. So these are the different learning points that you have taken from this case. So silent CAD can be present and extremely common in these diabetic and CKD patients. The underlying sepsis sometimes can mask the cardiac ischemia. So any new increase in troponin, and if there is any RWMA, treat it as ACS. And if his EKG changes are present, don't hesitate to do an angiogram. Anyway, we are going to do the dialysis in the CKD patients. And regarding the type 1 and type 2 MI, this case with positive troponin and RWMA in pulmonary edema, we consider it as type 2 MI. So we have not delayed the angiogram, and we reviewed the case immediately with the multidisciplinary team to save this patient. Thank you.
Yeah, thank you, Dr. Raja Ramesh.